All right. Welcome, everybody, to our September NASIT webinar on complications. We have a great set of panelists here to speak with us tonight about complications from RFA for thyroid nodules. From Australia, we have Catherine Sinclair. We have James Lim from Oregon, Deb Abraham from Salt Lake City, and Gary Say from California. I'm joined by Sophie Dream here from Wisconsin as well.
We're going to go through several case scenarios this evening and then have a Q&A panel at the end, or questions at the end. So please put your questions in the chat box and we'll try and address them at the end.
All right, number of cases to get through, so let's get right into it. All right, so Gary, you're in the middle of an RFA for a toxic nodule in a 37-year-old woman, and suddenly you start noticing this hypoechoic layer starting to grow kind of near your ablation zone. What are you thinking, and what are you going to do next with this?
Oh, sure. Immediately when I start to see a hypoechoic layering fluid, if you will, I put color on it, make sure that's surely what it is. And what will be top of mind is a hematoma that may be developing, either pushing on the strap muscles or on the adjacent nodule. I usually use ultrasound first just to hold a little pressure there. Definitely we use it to hold pressure over any vessel that might be oozing into the space before I recheck.
Any particular location that you see this more commonly? Anywhere you're more worried about this happening?
To be honest, a lot of these nodules are vascular. The few that I have had have been pretty self-limited. Those that are closer to the isthmus is when I have seen it, I guess, because there's probably a little less normal thyroid tissue overlying it than nodules that might be deeper within either the right or left lobes. But it's hard to predict who can develop these hematomas. But in general, I find that with pressure, they resolve pretty quickly without much buzz. And sometimes if it's just a small hematoma, I would just keep going. But if it really starts bothering them, that's something that then I would take a pause and reassess in a few days, and we can certainly bring them back and finish the case.
Sure. Gary or anybody else, so what are your thoughts on anticoagulation for patients undergoing RFA? Do you always hold it? Do you never hold it? Do you hold some agents and not others? What are your thoughts?
I initially had been more conservative, holding the anticoagulation as well as antiplatelet agents. I think these days, normally if they're on anticoagulation, I'd hold it. But if it's a baby aspirin or something like that, that's generally something I leave them on. I'm curious what the rest of the group does.
Yeah,
I would agree. Baby aspirin I would leave on, but all others I take off.
Cut out a little bit there, Catherine, but it sounds like baby aspirin you're okay with. Other ones primarily you're holding off on. I think that's typically what I would do. James, how about you?
Yeah, I was gonna say the same thing. It's interesting because when we do like a larger 18 gauge or 14 gauge needle biopsy, core needle biopsy, I am willing to do it under anticoagulation on board. But for the RFA, I definitely try to stop any anticoagulation when possible, and then certainly aspirin, like the rest of the group, baby aspirin, I'm willing to do with it on.
So Gary, back to you. You've seen this hematoma. It's pretty small. You're able to finish the ablation. Anything you do differently in follow-up?
Generally not. I just kind of do it the same way. In my experience, the hematomas resolve relatively quickly over just the course of a few days. Sometimes if it is larger, I'd bring them back. I bring them back just for an ultrasound myself, just to make sure that it's not pressing on anything that would concern me, that I could aspirate it out if necessary. But again, I can't recall the last time I've ever had to do that. So I think that these generally are pretty self-limited and resolve. And so I generally just follow up with a phone call to the patient.
Fair enough.
I think just to add on to that, some things that you can do Pre-procedure, you can put the Doppler on, kind of look at the vascularity where there may be major vessels, and kind of use that to kind of guide your initial approach. It's interesting, I see sometimes these hematomas develop even with the initial lidocaine hydrodissection that you do anterior to the capsule. So, but if it does occur, similar to Gary, oftentimes the first thing is you can hold pressure, and over the course of the procedure, see if it's growing or not. And then we standardly keep our patients in-house for about an hour post-procedure. And certainly if there was a larger hematoma, it'd be very reasonable to repeat that examination before they go home that same day, just to make sure that there's no enlargement of the hematoma.
I think it's a great point.
The other thing I've done as well is if one does happen, sometimes you can actually milk it out around the electrode by putting firm pressure, like everyone has said, at the time of the procedure, and it can actually relieve some pressure for the patient, because they often, if it's a decent sized hematoma, they will feel it. It can be quite sore. And the other thing I do is in post-procedure, actually for everyone, not just for hematomas, I do wrap their neck in a crepe bandage with an ice pack. And if they have a hematoma, I keep them for longer in the recovery room or in the waiting room, as has been said. And then I also advise them to keep the neck dressing on for 24 hours afterwards.
Yeah, I was going to say, James, good point. I think about the anterior location of a lot of this, that the venous plexus anteriorly, I think, can be a source of a lot of trouble with oozy bleeding for patients. And, the hematoma I've had, and I've heard this a few times, there can be a delayed kind of vasovagal reaction in some patients, either from us pushing too hard maybe, or from just stimulation from the blood. I'm not sure totally which, but I think it's a great point to maybe keep them a bit longer than you might otherwise if you send them out after 30 minutes or sooner. Maybe in those patients you want to hang on to them for closer to an hour, and just to make sure, because we have seen personally and heard anecdotally several cases of kind of that delayed reaction. So, all right, Sophie, should we jump into case number 2?
Yeah, so we're now going to talk about kind of preoperative, like pre-procedural, when you're evaluating a patient. Dr. Abraham, is your routine in terms of getting thyroid function labs, and how are you assessing whether or not people are a candidate in terms of their thyroid function for RFA?
All thyroid nodule patients, particularly the benign nodule, larger nodules, should have a TSH drawn before the procedure, well before the procedure. Besides that, careful history taking is valuable, because if there is a strong family history of autoimmune thyroiditis, the main focus with RFA being to conserve thyroid may not offer the protection that we think it does in patients with subclinical Hashimoto's thyroiditis. When you ablate one large nodule or several nodules, particularly the nodular Hashimoto's in one lobe, they may develop hypothyroidism. So pre-procedure TSH and post-procedure TSH is pretty much a given in most of the patients in my practice. The frequency can be anywhere from 1 to 2 months after the procedure if the TSH is normal, and if the subsequent measurements are normal, I usually stop. In patients with toxic adenomas, maybe I'll test TSH and free T4 and total T3 for a little bit longer in these patients.
Are you usually doing it every year then after you've ablated a toxic adenoma?
The toxic adenoma patients, it depends on where the TSH ends up. It natters around 6 months. If the TSH is in the mid-normal range, once a year TSH is probably sufficient. But some of these patients run a TSH in the 0.6, 0.4 range, normal being 0.34 to 4.0 in the lab that I use. If they run in the lower normal range, I keep them under closer watch because of early recurrence in these patients.
And then, so for patients that have euthyroid, and then you're checking their TSH in the post-procedural phase, if those patients have a suppressed TSH or low TSH, at what point do you decide to start methimazole or treat them? And then what do you usually see for the time course of the resolution of some of that hyperthyroidism?
There's been 2 patients in my practice who developed hyperthyroidism after ablation, who started with normal TSH. One patient was symptomatic, and the other one did not even have any symptoms. So this underscores the importance of testing. In most patients in the younger age group, there is no real risk for atrial dysrhythmia, particularly in patients who have coexistent cardiovascular morbidity. I might be a little bit more vigilant in those patients. With regards to treatment decision, it's purely based on their symptoms, particularly tachycardic symptoms, weight loss, etc., muscle weakness. And most often they resolve with beta blockers, either sustained release propranolol or metoprolol. I actually like atenolol because it's single-day dosing. It doesn't cross blood-brain barrier, so they don't feel sleepy in the daytime. So a simple beta blocker introduction in symptomatic patient would suffice. Most of these hyperthyroidism induced by radiofrequency ablation, I've also seen this with ethanol ablation. They are self-limiting over a period of 3 months to 6 months time frame. So conservative or minimal management, I've rarely ever needed to start on methimazole. In toxic adenoma patients, if they are quite significantly hyperthyroid to begin with during the pre-ablation assessment, I might be tempted to keep them on methimazole a little longer and then wean off after complete ablation 2 to 3 months later to see whether they need it. So it's a little different perhaps for toxic adenomas.
Does anyone else have anything else to add about either post or pre-procedural hyperthyroidism and experience with it? No. Okay. So the other question, I know that some of these are a little bit more minorist, but still pretty significant. Anything that you do to avoid skin burn or any techniques to avoid skin burn? And then if you do have that, how do you avoid it? Yeah, Dr. Sinclair, are you?
So look, I think with the current electrode design, with the internal cooling, and it's uncommon to get skin burns these days. There are a couple of things that I do. One is to be very sure you're keeping an eye on your cooled fluid bag, and to make sure that you know when you are getting low. And that usually comes down to having the assistant who's helping you with the procedure really be aware of keeping a close eye on that fluid and making sure that there is enough and stopping when there isn't, and changing the bag over. And then the other thing that I do, I keep my index finger on the electrode shaft, on the actual electrode applicator shaft, not just on the hand piece, because you can actually feel that when it's cool. And when it starts to get less cool, if your assistant or yourself misses that the bag needs to be changed, you can actually feel that change and you can stop immediately. So it's an added safeguard. And I always have a finger on that part of the electrode so that I can really monitor that myself as well.
Do you ever get worried about the skin being too numb for the patient to be able to communicate with you that there's heat, or?
So I do glance down at the patient fairly frequently during the procedure and at the skin side, not only to check for burns, but also for hematoma, as we discussed before. I think that adequate hydrodissection anteriorly does help lift that skin, particularly for isthmus nodules, lift that skin off of the nodule, and is definitely a protection mechanism against skin burns, as is the transismic approach by virtue of the direction that the electrode is passing, because you do have a buffer zone of thyroid tissue. So even if you inadvertently do pull the electrode back further than you realize, hopefully you won't be burning the subcutaneous tissues. I don't really worry about the patient being too numb to feel it, because I do keep a close eye on it and I've never had a problem with it. But and I think that a lot of the sensory nerve fibers run anteriorly in the capsule, so you do need a decent amount of local anesthetic in there, or the patient is extremely uncomfortable when you're ablating those anterior zones. And unfortunately, if you don't ablate them enough, then that leads to regrowth. So the answer is no, I don't worry about them being too numb, but I do keep a very close eye on both my approach hydrodissection and the temperature of the electrode shaft to prevent skin burns.
And are there any particular types of patients, like maybe thin patients or specific locations of nodules, where you're more worried about it?
So the isthmic nodule, as I mentioned, can be quite difficult actually. Sometimes with the isthmic nodules, you can push them off to the left or right side and get them away from the trachea, but they'll still be close to the skin. But they can be difficult to treat both by virtue of their proximity to the skin and subcutaneous tissues and to the tracheal cartilage. So they're the ones probably risk-wise, and also a person with a very thin neck where the nodule sitting very anterior in the gland at the front of the gland. Those are the ones where probably we have the most risk of skin burns. But again, using the mechanisms that I mentioned, it would be uncommon.
And if this does happen, what would you recommend in terms of treatment course?
So it depends on how severe the burn, but definitely ice to the area immediately afterwards. A lot of reported skin burns in the literature are fairly minor in terms of there's just some reddening of the skin that lasts for some weeks after the procedure, maybe increased pain for the patient. Significant skin burns, like, there's been case reports of them, but often in the earlier series where the electrode designs were perhaps not as optimal as they are now. I'm not sure if any have actually required surgery to excise the burn, but most of these actually heal up okay from my understanding.
All right, thank you. We'll move on to the next topic. That's from nodule rupture.
Good segue into this next topic. So James, and this is not James's case, this is just a case that I'm throwing James under the bus for, but 47 woman, she comes in 3 weeks post RFA with swelling, neck pain, which is worse than turning her head, and a fever. So what are your kind of initial thoughts when you get this news from your nursing clinic and you're going to see this patient?
Yeah, I think the typical time course is, we expect to see some swelling, and it should initially after the procedure within the first week, but usually by a little after the first week, most patients are feeling improvement in that swelling. And if anything, they're already starting to feel reduction in their initial symptoms that they were having pre-procedure. So certainly, just in terms of the timing of this presentation and the symptoms that are going on at this point, my concern would be for all the possible things that could be going on in terms of a thyroid nodule rupture, an abscess, infection, what's going on here. And so if they're not in the office, then I would ask them to come into the office so that we can do a physical exam, an appropriate evaluation, and ultimately stick an ultrasound on the neck and try and see what's going on. Those are wonderful pictures. With these pictures, I'd be more concerned, especially with what appears to be pus draining. I'd be a little surprised, first of all, because honestly, infection is actually very uncommon. And even with a thyroid nodule rupture, we find that most patients are not dealing with an infection so much, and we can usually just manage them with supportive care in terms of kind of anti-inflammatories and just giving it time to resolve. This looks pretty aggressive. I would probably start by sticking an ultrasound, try and see if there is a pocket, and see what else is being expressed. Probably would get additional labs in terms of white count to see if there's any systemic inflammation. And yeah, I guess I would be concerned that there is a brewing abscess under there, and making sure that we have adequate drainage and making sure that there is, the patient is starting to get better. This is a pretty extreme example.
I'll go one step further as this continued to evolve. And yeah, it's a pretty extreme example of nodule rupture, just like you were saying. But it kind of gets into the idea of a little bit of skin burn as well from the entry site there. And, obviously skin breakdown here from all of this ultimately. You were kind of saying, abscess, also kind of potentially could this be just sterile pus, in this nodule rupture, not necessarily this case, but in general. What are your thoughts on that?
Yeah, I mean, it's possible. It may be just all this inflammatory necrotic tissue from the ablation that's coming out. I think given the presentation with the tenderness and the fever, I think I probably would err on the side of over treatment with adding on antibiotics in this specific scenario. Although with most nodule ruptures, I probably would think that we wouldn't need to, but this is one case I probably would highly consider it. And then I think the other consideration is, do you just watch this, or are we concerned enough that we actually open it up and kind of debride the tissue so that you can kind of help the healing along? I think that's kind of my surgical mentality here, kind of
Yeah.
coming out.
Yeah. I can put a needle into it, but you're the one who would have to open this up. So what kind of things would push you into, being more inclined to maybe open this and treat it surgically versus being more conservative, like you said, antibiotics and just kind of watch and supportive care?
Yeah, I think I'd be curious to see what the rest of the crew has to say, but I think I can see clearly in this case, they did not open it up. It seems to they just kind of let it evolve on its own. I'm not sure what other kind of supportive measures they did in terms of antibiotics or steroids or what. Yeah, I think potentially, knowing that these things rarely become infected, I may give it a little bit of time to see how it evolves, but very short. And if things seem to be getting worse very quickly, or worse over the next week or so, I probably would personally feel more comfortable just kind of opening it up and debriding it and kind of cleaning it out. And I think it may end up with a cleaner kind of resolution than having a separate opening kind of on the lateral edge there.
Gary, you're an IR like me.
Yeah, I
What
was
are your
gonna
thoughts
say,
on this? How would you approach something like this?
yeah, we've seen only a handful of these. They're pretty uncommon, but obviously a major complication. Uh, so early on, we were more quick to jump the gun. Again, it's not that we have a ton of them, but jump the gun with antibiotics and percutaneous needle aspiration. And talking with colleagues that do this across the nation as well as within the literature, it seems like the vast majority of these are pretty self-limited. As James was saying, if you just do supportive care, you probably don't even need to put a needle into it. Obviously, if they're showing more and more signs of infection, then certainly antibiotics and helping to remove whatever fluid collection and putting it for culture may be warranted. And obviously, from our perspective, trying to go through normal skin or something, because as you can tell in that patient, that skin is very thin overlying that rupture that's brooding under the skin. So really trying to find some normal skin as opposed to going through the erythematous skin to prevent some sort of fistula. We did have one patient that had a similar outcome where we did drain it, and he did form sort of a big hole where we aspirated it. And he was supposed to get a flap over that area, but over months it kind of just resolved on its own. And I have heard a few other colleagues that, again, on the East Coast that have seen similar things, and it seems like, less is more in this situation. Obviously, this particular case seems pretty pretty bad, but for the few nodule ruptures that I've discussed with colleagues and that we've seen, perhaps less is more, and not quickly jumping the gun and putting a drain in it or aspirating if it's not too erythematous. There's no fever, there's nothing else. So from our experience over the last few years, I'm leaning more and more towards conservative management, as James was saying.
Anyone else have experience or thoughts on how approaching this? Catherine?
I've had two ruptures, or at least one definite one and one probable one. There was a nice article from Prof. Bayek's group, I believe, sort of classifying these into anterior, lateral, and medial ruptures. I've had one medial and one anterior. This one that was just presented with the photos was an anterior. My medial one actually made his recurrent laryngeal nerve weak, and he actually was in he had a very large nodule, was in a bit of respiratory distress. I did aspirate that one. I sent the pus off. It was sterile. Nothing grew. I did treat him with IV antibiotics and steroid, and it settled. The other one settled with steroid and antibiotics orally. I do think that these ruptures occur partially because of the size of the nodule, with very large nodules. And I do think that there is an element of weakening probably of the capsule from the ablation procedure itself, combined potentially with microbleeding, as has been reported in the literature. But the big, I think the big kind of the question always is, do you put them on antibiotics or do you not? I see it as relatively harmless for them to be on antibiotics, so I have. Neither of mine was septic though, so maybe there is a difference between an abscess and an abscess per se and an actual and a nodule rupture. I'm not sure. But the interesting thing, both of mine followed upper respiratory tract infections at around 4 weeks with profuse coughing. Actually, both of them had COVID. So there maybe is an element of increased pressure, cough, also precipitating these. But I agree that most settle conservatively, luckily, and I'd only probably aspirate if patients had some degree of airway compromise or significant discomfort, as my one patient did.
You mentioned capsule weakening. Do you take a different approach when you see a nodule that really bulges, anteriorly or medially? Do you ablate sort of that bulgy portion less, or do you just treat it and
it's a good question. I treat it, and I treat it with slightly lower power now, as I would in the posterior zone. But I do treat it fully, because otherwise you get regrowth. There are usually a lot of vessels that run in anteriorly, and you really need to get that area, in my experience, or you're going to put yourself up for a regrowth phenomenon down the track. So I do use slightly lower power. Often patients are very sensitive in that area, even with local anesthetics. So I wouldn't usually use 60 or 70 watts right at that front zone, but I do treat it fully.
Sounds good. Dev, do you have any thoughts on this? Have you run into this, or what are your thoughts on tackling this?
Fortunately, I haven't run into this unfortunate complication. But having spent some time with Dr. Beck, we had similar discussions in the context of a patient who called in with some swelling, but resolved conservatively. His view was to treat conservatively without any aspiration by and large. Even though it points to the skin and it's soft in areas, at least in that image that was shown of the patient, there was some softening areas. As Gary pointed out, the skin is extremely thin. It's tempting to drain it in an attempt to avoid a fistulation de novo, but by aspirating, I think you might precipitate a fistula. So I think conservative is the way to go. The most important thing perhaps is to avoid patients to avoid massaging and putting pressure on the nodule after the ablation, because there is an inherent tendency when there is bruising and swelling to apply pressure, apply heat, apply some of the things they do for relieving symptoms, local symptoms, probably we are not aware of. So I make an explicit plea to patients not to put pressure, even though it's tempting to do that. As the lidocaine resolves, there is often itching at the site because of the nerves misfiring. So the tendency to rub should be avoided. So that's what I tell patients. Sometimes in the winter months, people wear tight clothing around their neck. I also ask them to avoid that, because all of these lead to some inflammatory response, perhaps. I don't know, but I ask them not to wear tight clothing around their neck also. I don't have data for it, but I'm just doing this preemptively.
I think
great point.
I was going to say, I think Catherine makes a good point that the bigger nodules are usually the ones that we see this occur in. I'm curious as to what I know, the literature says various things, 25 cc's or greater is kind of on the bigger side. We've certainly done 50 cc nodules, but we'll just stage it. We'll do the bottom half and the second, and we'll bring them back and do the top half of the nodule. And again, the very big ones will go to embolization. But I'm curious what's your feeling about size-wise, and particularly if the larger the nodule, which again I do think so because of weakening of the anterior capsule, are more prone to nodule rupture. I'm curious as to what you guys, how comfortable you are up to what volume or what sizes you're doing this, and if you do sort of stage it, if it is larger.
I don't tend to stage it because of the cost phenomenon. Patients are paying out of pocket. They can't afford to have another electrode used. So I treat these large volume nodules in one hit. And I really haven't had a lot of problems other than that one case, possibly two. The second one, she was also on anticoagulants. There were some other factors involved. So I don't stage them. I do treat them fully. And now with the adjustable tip electrodes, being able to use 15, 20 millimeter tip and deliver a lot higher energy, I still haven't run into any problems yet, touch wood.
Yeah, similarly, we don't stage the larger nodules. Kind of the same idea. If we can and the patient's tolerating the procedure, try to ablate the whole thing all in one go. I would say kind of our cutoff for larger versus smaller is that 50 cc kind of that you mentioned before. I think staging, may make sense. I've heard of some, if you have a substernal component that you can't actually visualize on the ultrasound, ablating the portion that you can see and then coming back to ablate, that second portion, if it pulls it up into the neck from the mediastinum. So I think that's out of necessity that you would stage it in that situation, just because you can't safely ablate what you can't see down there. But yeah, I think going just to answer the point about the risk factor for nodule rupture, it's interesting. We've had a couple of cases at OHSU now, both managed very conservatively, no antibiotics, and just giving it time and supportive care. But one was large. One was on the larger end. I think it was about 50 cc's, but the other one was quite small. And I think that one was, if anything, it was more anterior on the anterior surface of the thyroid. So I think you kind of see both of the factors that have been discussed so far. I would say that we've had presentations of both of those kind of situations and risk factors getting shown in our patients.
All right. Sophie, should we head on to the next case?
Yeah.
Here we go.
So I'm gonna pick on Dr. Abraham a little bit. So say you have a 41-year-old male who you're in the middle of ablating a nodule, and then you're at the inferior edge of the nodule, and the patient's voice suddenly becomes hoarse. What are you concerned about?
Recurrent laryngeal nerve or vagus nerve ablation accident.
Yeah. And how would you decide which, or I guess does it matter which one you're worried about?
So the vagus nerve can be mapped in most people because it's a fairly large nerve and it's located in the anterolateral aspect. Sometimes there is a posterolateral variant. There is also a medial variant. So I make an effort to map particularly the vagus and the sympathetic ganglia in all patients before the procedure. And particularly in the caudal aspect of it, it can be quite variable and it can be closer to the midline. So make an attempt to visualize the nerve before the ablation, and even prophylactically doing hydrodissection with dextrose, 5% dextrose. I've attempted. Whether it was needed or not, I do not know. But when there is a change in voice, the first thing would be to abruptly stop ablation before doing anything further. The next step is repositioning the needle. Sometimes when the ablation occurs, it's very difficult to tell because of the echogenic bubbles, where the tip is when you stop the procedure. I try not to move the needle electrode that much. I try to reposition it by a millimeter or two. And usually reassure the patient and prepare for 5% cold dextrose injection straight away. If the patient's voice changes back to normal immediately, then probably that is not necessary. You move the needle away from it. But if it doesn't, definitely 5% dextrose where the ablation occurred outside the capsule of the thyroid should be done. That's what I would do.
Is there anything that you do during the procedure, like to have the patient, do you have any protocol to make sure the patient's talking to you, or anything you avoid just to be able to assess their voice?
Yeah, of course. You just ask the patient how they're doing, how they're feeling, have they noticed any changes, and ask a question that makes them talk, particularly the quiet patients. Some patients chat innately throughout the procedure, and that's what I've been doing. But you can also ask them to say E and monitor the vocal cords using the ultrasound transducer. E and sniffing. Sniffing induces abduction. E does abduction, so you can actually visualize the cords too in some patients if you need to. So that is real-time vocal cord monitoring by patient participation during the procedure using ultrasound can also be done.
And Dr. Sinclair, what would you do in terms of if someone does have a vocal cord injury or nerve injury that doesn't get better, in terms of like for that procedure, and then how do you have that patient follow up?
Yeah, so at the time of the procedure, I think the most important thing is if it happens, don't panic. Really take note of where you're ablating. Really look where the electrode tip is, because as Deb said, if you want to use cold dextrose to try and cool the nerve down effectively and get some potential back, you need to know where to inject it, and it'll be much more accurate if you don't panic and pull back on the electrode. So that's the first thing. This other thing I would say, I have people constantly talk to me when I'm ablating in the danger zones at the back of the thyroid, or if there's a medially placed vagus nerve. And I call it continuous auditory voice assessment. So I have them count in a very monotonal voice, but a fairly loud voice. It's pitch inflections that tend to move the larynx and thyroid when talking. So if you have patients talk in a fairly monotonal voice, I would say 95% of patients can speak without actually moving your image significantly. And I found that very useful. I haven't had any nerve injuries since I started that protocol. Whereas before I did that, I had two with just intermittent kind of checking of the voice during the procedure. So that's one thing. I think in terms of follow-up, as you asked, when these patients have had hoarseness, you can hear it immediately at the time of the procedure. You can confirm it either with ultrasound if you can get a good view, or the gold standard laryngoscopy, which I do if there's any suggestion of hoarseness before or after the procedure. And then I follow them up more vigilantly than I would a standard RFA patient. So I do and frequently call them once a week to check on them. I have them email me or call me if there's any issues. These are patients that I give direct contact options for. I want to be very sure that they're not aspirating, that they're able to drink safely, because if there is a paralyzed cord, that is a risk if it's not sitting in a very medialized position and not able to shut the glottis off properly. And luckily, both in the literature and in my luckily limited experience with this, it does seem that these thermal injuries to the nerve generally recover, which is a little different from the quoted nerve palsy rates for surgery, for example, where there is a significant permanent, not significant, minority still, but a 1% perhaps permanent nerve injury rate. With ablation, it does seem to be less, and so you can kind of counsel patients, according to that as well. So my follow-up, weekly phone calls till it recovers. Luckily, it usually recovers within a couple of months, sometimes a couple of weeks, making sure that they're safe to swallow liquids. At the time, if an injury happens, I do actually have them swallow some water so I can check they're not coughing. And if they are coughing, I would organise, I haven't had to do it yet, a speech therapy review, speech pathology review for a swallow study to check that there's no significant aspiration going on.
Dr. Lim or Dr. Say, do you have anything else to add?
I would say just if you are doing ablations, to kind of walk through this process and make sure that you have kind of the materials that you need to be able to do a rescue. Make sure you have the D5 in in a chill, in a refrigerator or something nearby. Make sure you have appropriate needles. Sometimes it may be easier to access with a spinal needle, a little bit longer, deeper, that type of thing. That your usual needles that you're using for just local anesthetics may not be long enough. And so I would just make sure that you have kind of all those materials available so that you're not running around in that rare situation it may happen. But aside from that, I would say I agree with everything that's discussed so far in regards to it.
Yeah, I agree. There's nothing more I would add. It's just the one technical aspect of the D5 rescue I'd noticed that is if sometimes you are gassed out, like let's say you start having the hoarseness, the majority of the nodule, but you can stick it higher and that cold D5 will spread inferiorly. But no, I agree with everything that's been said.
We'll move on to the next scenario, just in the interest of time too. Yeah.
All right. So James, again, you're in the middle of an RFA for an upper pole nodule in a 54-year-old man. He has to complain of ear pain. How do you approach folks complaining of sort of pains going to jaw or ear, things like that during the case?
That's an interesting one. I think when we first started doing RFA, we noticed pain radiating to the jaw, to the clavicle. And so at least, I've started doing these superficial cervical plexus blocks that are hopefully going to numb up the greater auricular, transverse cervical nerves that wrap around from the posterior border of the sternocleidomastoid. And I do that standardly in all my patients, kind of a bilateral, in addition to the kind of the local that's on top of the nodule itself, like we standardly do. And so I've actually anecdotally have had a reduction in patients complaining of kind of this referred pain. And so if I've done that and if I haven't, then I would try adding that on or try and go more lateral in terms of the local anesthetic. And if I think I've done all the things I can do with local anesthetic, then I probably would just wait a little bit, give it some time. Usually these types of pains will usually subside once you've actually stopped the RFA, the generator, and just give it a little bit of time for the patient to become comfortable again. Move a little bit to a slightly different spot and try again and see if the patient has any additional kind of discomfort. And usually just the kind of moving along, the patients are able to tolerate and the pain subsides. But yeah, those are my tricks.
Fair enough. Dev, how do you counsel patients about pain during the procedure? Anything you do in particular to help minimize? Do you do blocks like this? Do you just use local anesthetic? What are some tips or tricks you might have?
I usually ask them to take 1 gram of Tylenol an hour before the procedure, routinely. I ask them to avoid NSAIDs until 24 hours later. It's theoretically increased risk, potentially of antiplatelet effects. So that is a given in every patient. The second thing is liberal block, starting at the lateral margin of the nodule, all the way medially to the skin entry site at 3 levels, about 1 or 2 centimeters apart. Total volume of lidocaine can be shy of 10 mils in these patients. I usually don't have much of a problem if I block liberally. As to the auricular pain that some patients complain, I've absolutely be able to resolve that by just turning off and reducing the wattage. Usually happens in the lateral capsule and the posterior capsule, actually, posterolateral capsules. I don't know the significance of what nerves, because there shouldn't be, but nerve plexus, you have no idea what happens. So reducing the wattage, repositioning In that situation, I usually liberally reposition the needle to alleviate the symptoms, and most times it resolves by itself. But blocking liberally, starting from lateral to medial, makes a huge difference.
Excellent. Gary, any other tips and tricks you want to share?
No, I would agree. I find that being liberal with the thyroid capsule lidocaine usually keeps me out of trouble. We do a milligram of Versed PO for our patients beforehand just to take the edge off, and I have found, yeah, decreasing the wattage seems to resolve it without much. It'll take you a little bit longer to do the ablation, but it seems like if I just crank down on the watts and then go back and give a little bit of parathyroidal lidocaine, seems to do the trick. So that's worked well for us.
Fair enough. All right. Last topic. Sophie, you're on mute there still.
Thank you for that. I said, Dr. Say, I'm going to ask you, because we just picked on Dr. Lim a couple times. So let's say you have a 50-year-old woman who underwent RFA of the isthmus nodule, and now she presents 24 hours later with pain and dyspnea on exam. She has some subcu emphysema. What are you concerned about, and how do you approach this patient?
This is a dreaded thing that I hope never to see, but certainly we're thinking that there is some compromise to the trachea. Thermal injury to the trachea. Generally, when we're doing the case, the patient will start coughing, so you'll know, and then you can either redirect or decrease the wattage, for example. But what I'd be most concerned about for 1, 2, and 3 is injury and perforation of the trachea. And me being an interventional radiologist, obviously I want to get imaging, but I'd call a surgeon first. But getting imaging to lay it out, find out exactly where it is, and deferring to my surgical colleagues as to the appropriate management for this.
Dr. Lim, it's a great segue. What would you do when he calls you? I think you're muted too.
Yeah, no, I think this is an interesting situation. I feel like it's interesting because if they have such rapid presentation, I'm almost wondering if it's not a thermal injury. I wonder if it's more of a perforation, maybe perhaps you've gone through, because typically, this has been reported. I've only, I think, seen 2 case reports, in terms of tracheal necrosis secondary to thermal ablation. They usually present 1 week out to 3 weeks out, and so typically when we think of a burn injury, we think that it needs time to kind of present. And so I guess so
if you have a CT and it shows subcu emphysema, looks like a rupture, where do you go next from there for that person?
probably would call Dr. Sinclair.
I know, I was about to say.
But yeah, I would think that you would probably need to, potentially take the patient to the operating room, potentially evaluate the trachea and potentially debride kind of the area of injury. I guess it's possible to consider antibiotics and kind of monitoring this patient, but I think that would be very, I don't know. I would lean on one of my tracheal specialists and kind of ask them what would they do.
Dr. Sinclair, what would you do?
So I think it depends on the size of the presumed perforation or injury. And I agree that if it's happening 24 hours after, you have to wonder if it's just the electrode having gone through. Hopefully, usually when patients are under general anesthetic, patients are under local anesthetic, they'll know if you're near their trachea, you'll know about it. So it'd be unlikely that you'll go into it and then actually ablate the lumen of the trachea. It'd be more likely you've just got into it and come out of it. So there is a role potentially for conservative management if it's looks like a very small puncture and there's not a lot of subcutaneous emphysema, no airway compromise. This patient definitely needs to be observed in hospital, in-house. Intravenous antibiotics or antibiotics should, I think, be started in these situations, and with a very low threshold to go in and explore early. and have a look and repair as needed, which may be able to be, a debridement, primary closure. It may need some sort of flap. We don't have a lot of literature on this. We don't have a lot of experience with this, but we'd sort of treat it similar to how we treat a tracheal injury from trauma, except this is a known trauma, and have a low threshold to explore, I think, in these situations.
And then how would you follow this patient long-term? Say they did have something that you did have to repair from a thermal injury.
The main thing is, the main thing to watch for is tracheal stenosis, that can develop after tracheal surgeries. And so the patient will be initially reviewed probably every 4 to 8 weeks, maybe a little more frequently in the very immediate post-op period. They'll be in hospital for a number of days being observed for airway safety. Again, the size of the injury will determine whether they need a tracheostomy, what is actually needed as a part of that surgery. But they will need sort of much closer follow-up than the standard 1, 6, 12-month follow-up that we would give for an uncomplicated radiofrequency case. And that's really determined just by the extent of what is required.
And then this really anyone can answer. Is there anything you guys do to avoid this?
Yeah, I mean, I think one point, and I remember Dr. Sinclair saying this way back when, I think in both of those case reports that I remember reviewing, those patients were deeply sedated or under general anesthesia. I think those are situations where the patients are not able to sense anything in that area. And similarly, for that reason, I remember Dr. Sinclair, mentioning never to put any local anesthetic onto the trachea itself and potentially numbing that area. And so I think that's definitely, having an awake patient able to feel and sense kind of any discomfort in that area, and having them awake and not anesthetizing those areas. Those are kind of key. In addition to obviously having a good visualization of your probe throughout the whole, procedure, and making sure that you know where it is relative to the critical structures.
I would wholeheartedly agree with those points. I think, avoidance of general anesthesia, this is the big complication that can, that you're not going to know about if the patient can't warn you by coughing or feeling the discomfort if you're near their trachea. And I think the local anesthetic thing is important. Low power if you're ablating an isthmus nodule that you can't push off the airway. A lot of them you can push to one side or the other, but if you can't, you need to be very aware. And patients actually won't tolerate you using high powers near their cartilage if they're awake. They do feel it, they will cough, they will feel a lot of discomfort. And so you can be guided by what they feel and tell them. You really need to know what they're feeling when you're ablating these nodules that are at increased risk for visceral, particularly tracheal injury.
Just like one final closing question, and then if you have any tidbits, we're happy to hear them. But given we've talked about all these complications, when you consent people for RFA, do you guys talk about surgery? And if you do you address potentially having to take their thyroid out if they need an emergent surgery?
I address it mainly with regards to bleeding and definitely the risk of hematoma, which probably for me is my biggest feared complication, a hematoma that's not just superficial, that is an expanding hematoma that I can't control and that the patient actually needs surgery for. And there have been case reports in the literature of patients having to go to surgery for bleeding. So I do speak to them about the potential need for surgery, but more in the setting of uncontrolled bleeding rather than I do warn them obviously about visceral injury, but I don't really go into intense detail about what might be required in those settings in the initial consult.
Any
Yeah,
closing?
I think go through similarly, kind of all those things. Oftentimes in my consultation, it's usually a discussion of RFA versus surgery as the two options. And so they kind of go back and forth. And then ultimately if RFA is chosen, then kind of going through the different areas of potential thermal injury and, kind of going through all the risks that we just discussed now. but I think I leave it at just needing additional procedures potentially to kind of treat whatever complications are there. I think it's kind of understood that surgery is on the table potentially after, if necessary, but not so explicitly, I say. It's pretty rare, thankfully.
So I also counsel patients for all potential complications, and I tell them that I do the best I can to avoid all these complications. And I also counsel them that, particularly for benign disease of the thyroid, I tell patients that I deliberately undertreat, knowing well that a complication for a benign disease is unacceptable or probably not the right thing. For malignant disease, it becomes a little bit difficult because you're going for a little bit more aggressive ablation to get the margins, particularly with smaller papillary thyroid carcinomas closer to the trachea. And I tell them, if I can move it with hydrodissection, which most times you can, then that's the way I avoid it. And in patients where if you inject and there is no separation between the trachea and the tumor, I do tell patients that I did undertreat it also for safety reasons. So it's trying to explain to the patients, and they buy into the situation that is unique to them beforehand, does alleviate some tension from both ends.
I think that's a really good point, Deb. That's something that I actually tell patients as well, that I will go easy in that danger zone or proximate to any critical structures, and that potentially could increase risk of regrowth in those areas, but that's better than them having an injury. And patients obviously agree, but I am also very upfront about that, and that's exactly what I say to them, that I will use lower powers and potentially undertreat with benign disease, because we don't want them to have a complication, and patients are on board with that. It's just something they have to accept as a part of ablation. There is this risk of regrowth and need for second procedures, and so I think that's a really good point.
All right. Do we have time for a couple quick questions here? We're almost at the end. There's some questions in the chat. All right. I think we're looking good. About a minute left, so I think we're at a wrap here, guys. Thanks everyone for tuning into this webinar, and we'll see you next time.
Thank you.
Thanks
Thank
everyone.
Everybody.
Yeah.
Thanks.